Hopefully you can hear me now. Thank you so much. I really appreciate the opportunity to be here with you all. I know there will be some redundancy of what's already been discussed and what I'm going to talk about, but within the realm of talking about studies in oligometastatic lung cancer, current data and definitions, I'm hoping to give a bit of an overview of kind of how we got where we are right now, and then really where surgery fits into that space. What does oligometastatic lung cancer mean? I think to make that very clear from the beginning is going to be important to our shared understanding here. So, we know that cancer has spread beyond the lung, but when we say oligometastatic, we mean that it has only spread to a limited number of spots. And you can see variable number definitions in terms of numbers ranging anywhere from 1 to 3 or even up to 5. But I would say the most widely accepted definition is when it has spread to anywhere up to 3 spots. And that's the number that we use for a lot of our studies. And so, in general, when we see other studies or other treatment patterns that may include up to 5 or 6 spots, it doesn't mean that the aggressive treatment in those situations may not be valuable, but we don't typically consider that oligometastatic. The point here is that we think it may be a distinct spectrum of advanced cancer where aggressive treatment of visible disease may actually be of particular benefit. And that's why we talk about it a lot in this space. As we clinicians and scientists think about oligometastatic lung cancer, we recognize that this may have potential for more aggressive local therapy. And I'll talk a little bit more about what local therapy means in a moment. But we think of this oligometastatic state as one that is metastatic but has limited disease burden. And the tumor biology in this circumstance may be distinct or different than what we would see from individuals who may have many greater sites of metastasis. So, what does local treatment look like in these circumstances? We'll often hear the abbreviation LCT, which stands for local consolidative therapy. And local treatment means treating those cancer spots directly, not just with a drug that travels through the veins and hits every cell in the body, but specifically treating those spots where the cancer is. And the options may include a variety of different strategies: radiation, which may be in the form of SBRT to the lung tumor or spots within the bones or adrenal gland, anywhere else. You might have heard of CyberKnife to brain metastases, surgery to any of these spots, but particularly to the lung tumor itself. Or what we're seeing more often is a combination of these different strategies to try to comprehensively treat all the different spots all at once. And I do want to be clear that this is often used along with medications that may be given through the vein or through by mouth, but not instead of those medications. And so you'll hear us often talk about the landmark oligometastatic trial. And I think about this study a lot. This is a study that really changed how we think about local treatment in limited metastatic cases. That's why we call it the landmark study. But this was one that's now almost 10 years old. And I think the important take home points from this study were that it really helped us realize that by treating aggressively the local spots of disease, in addition to drug therapy for patients who have limited metastatic burden, that we can see improved time without progression, which you see on the graph on the left, as well as increased time until new spots develop, which you see in the figure on the right. So this is really important, and it changed the way that we think about local therapy for patients who have stage 4 lung cancer. We also saw with that study that came out again almost 10 years ago that individuals who had comprehensive local therapy, so this is providing local therapy to all sites of disease that are present at the time that one is diagnosed, that individuals who had that type of really comprehensive local therapy had improved time until progression, increased time until new metastases, and even improved overall survival. One of the questions we get a lot is, who are the right patients? So which subgroups of patients are most likely to do the best with local therapy? And for me as a surgeon, I think about who's going to do the best with surgery. So who benefits from this type of local therapy? We did a review of almost 200 patients at our hospital who had this type of local therapy with surgery or with radiation, and compared those who had comprehensive treatment of all sites present at the time of diagnosis to those who didn't. And so ultimately we came up with a group over 18 years of almost 200 patients. And I do want to be very clear when I show you the results from this group that the years were 2000 to 2017, and very few of those patients at that time had what we know as oncogene-driven disease or molecular profiling that would allow them to get special treatments for mutations like EGFR or ALK or ROS1, other different types of mutations that we can treat at this point in time. So with that group of patients, we saw that by giving comprehensive local therapy to this large group of patients over a period of over 18 years, in an era when our drugs weren't even that good, we still saw improved survival for patients who had local aggressive treatment to all sites of disease that were present at the time of diagnosis. The next thing we did was try to figure out who would have better overall survival with that type of aggressive, comprehensive approach. And in this study, we showed some things that I think may be quoted, may be knowledgeable to other individuals, but I want to point out that they don't necessarily apply to everyone. So in this study, we found that individuals who maybe didn't have as large of tumors, as much involvement of lymph nodes, patients who didn't have bone metastases, tended to do even better with this comprehensive local therapy. But I want to point out this was more of a historic group of patients who, number one, were older than many of the advanced cancer patients that we see today. And number two, very, very few of them, to our knowledge at the time of their treatment, had targetable alterations that we could treat with a targeted therapy. And so we've actually found since that time with other studies that in patients, for example, who have EGFR mutations and are on targeted therapy, even with bone metastasis, operating with surgery to all sites of to the lung cancer itself within the lung, and then having comprehensive therapy to the other sites of disease, typically with radiation, is beneficial. And I think that's really important to acknowledge for any patient, for any caregiver, and for their care team, that when we look at studies that exist in any patient population, you really have to be sure that it applies to that individual. So if we have a study that maybe shows that surgery or radiation isn't particularly helpful in certain groups of patients with stage 4 disease, you have to look at who was in that study, because we typically tend to see the best outcomes for that type of approach for individuals who do have some sort of oncogene-driven disease. And so I don't say that just to speak about people who can receive targeted therapies, but mostly to acknowledge that we recognize that there are large groups of patients, caregivers, advocates who are looking at these scientific studies, as well as practitioners who are trying to apply these data to the day-to-day treatment of patients. And if the patients who are in the study don't share the same treatment characteristics, the same health status, the same additional medical problems as the person for whose care we're trying to come up with the best plan, we have to acknowledge that the data have to apply to the individual. So I know that's a bit of a side point, but I think it's really important because our data in this space are quite limited and they may not apply to everyone. Sometimes we have to think outside the box.